Great, thank you. So the content that I will cover today is I'll give a background of the evaluation of the double fortified salt program in Uttar Pradesh, India, that we conducted with a consortium of partners that I would be remiss in not acknowledging at the start of the presentation, ranging from colleagues at GAIN, the UP-USI coalition, who was a local counterpart in the UP and led all of the laboratory analyses, our colleagues at SGRI, MDL, DCOR, and our research partners at Emory. Many of these colleagues are here on the call, as well as colleagues at TINI, who supported the implementation, as well as the Bill and Melinda Gates Foundation, who funded the program, as well as the independent evaluation. So the goal and research questions of the evaluation was to generate relevant and high quality information that can be used by the state government of UP and their partners for decision making that are related to actions to address iron deficiency and anemia of women and children. So the specific research question that our evaluation sought to answer was, does double fortified salt delivered through the public distribution system in Uttar Pradesh, India, improve iron status and anemia among non-pregnant women of reproductive age? So that's the specific question we sought to answer. To reiterate some of what has been said relative to the program, I think we know that there's a high prevalence of anemia in Uttar Pradesh. And consequent to this, the state selected 10 priority districts for distribution of DFS through the PDS system. The idea there was to test the potential as an approach to address this prevalence of anemia. And DFS was distributed at a subsidized price through this platform. So for the evaluation, 5 districts were chosen as intervention sites, and 5 neighboring districts were chosen as comparison sites. I think one thing to note was that there was an important delay in distributing DFS after the baseline for several programmatic reasons. So in terms of timelines of the program and the evaluation, we conducted a baseline survey between October and December of 2016. And after a 13-month gap, DFS was added to the PDS basket in all intervention districts over the period of January 2018 through March 2018. Following a period of implementation, we conducted a midline survey to see how much DFS was, how much coverage of DFS was being realized through the program, and what the reasons for uptake, high or low, was. And also to see whether there was enough coverage to justify an impact evaluation. We had initially intended for the delivery of DFS to occur for 24 months, but for several reasons, the DFS supply ceased between the period of March 2019 and May 2019. So we accelerated the endline survey and conducted it in the period of June to August 2019. So the main, the critical points to remember from the slide are that there was an interrupted supply of DFS for 12 months. We conducted a midline survey and the endline in August of last year. So just to recap on the baseline survey findings, we confirmed through this baseline a high burden of disease among women of reproductive age, iron deficiency in almost half of the women that were assessed, anemia in 36%, and iron deficiency anemia in 25% of the women of reproductive age. And among children, anemia was 61% in preschool age children. And we've confirmed that 80% of the population reported using PDS regularly, which confirmed its potential as a delivery platform. From this baseline, we therefore concluded that there was indeed a high potential for a demonstrable impact of the DFS program on iron status of women and children, giving us the confidence to proceed with the evaluation in essence. So Something that is that might be important to point out or to note that is relevant to some of the questions Prof. Godbole raised around learning how to make this program work or interpreting these findings is that the evaluation measured impact, but also it involved an in-depth review of program implementation guided by a simplified DFS program impact pathway that our Emory colleagues developed in collaboration with TINI. And the pathway, in essence, this is a simplified form. What it indicates or illustrates is that high quality DFS premix combined with high grade iodized salt along with government processes that ensure DFS reaches the public distribution system are key to ensuring that DFS is sent monthly, that community mobilization occurs and all of these elements of delivery happen. And if these issues are in place, then adequate quantities of quality assured DFS can be present at the fair price shops for sale to beneficiaries. The DFS package can reach the fair price shops in every intervention district, and beneficiaries are aware of DFS availability at the FPS. Assuming these things happen, then we can be confident that beneficiaries will or consumers will purchase DFS, and that DFS will be regularly used by consumers in their daily cooking for most food purposes. And these issues having been achieved, we can then plausibly assume that we'll see an increase in body iron stores and consequently a reduction in anemia among beneficiaries. So this is the assumption of how the program would have worked in order for it to achieve its desired effect. And the things to note here is that at the midline assessment, we wanted to confirm these issues of coverage so that we would be sure that when we went back at endline, we would see these biological changes. So just to highlight some salient points from the midline, the bottom line was that DFS was known and purchased by the majority of consumers, but there was a relatively low proportion of households that utilized it for all salt needs. So if we look at the coverage cascade for DFS, we see that 82% of respondents had ever seen or heard of DFS, and an almost equivalent proportion had ever purchased DFS. So knowing of it and procuring it was quite high. But we found that 36% used it in at least some food salt needs, and 23% were currently using it in on all of their food salt needs. And this bottleneck in DFS uptake and use can be explained by some of the changes in the organoleptic changes in the characteristics of the salt that were observed that our colleagues at Nutrition International will speak more about from what I heard. And a critical point or quote that we identified or that we elicited from women interviewed was that we put less salt in the food while cooking. When I start eating, I add DFS in my food. It is fine. So there were a lot of rich findings that are outlined in my colleague Shruti's paper that was just out that give an insight on why we see this high coverage and relatively low utilization of DFS and what could be done to counteract this challenge. But circling back to what it means for the end line. Because of this challenge, and the fact that we conducted the midline to see whether the program was evaluable, whether it met the minimum criteria for us to proceed with the impact evaluation. We confirmed that two of the districts were indeed evaluable, and these were Etawah and Orea, and they were included as interventions. And their neighboring matched comparison districts of Manpuri and Karnaj were included as the comparison. They were already the matched comparison at baseline. We estimated that we would need to sample 6,200 women of reproductive age at endline, and we managed to achieve and exceed this this sample size. In the interest of time, I'll move on to the endline design. So the primary objective of the endline was to estimate the impact of DFS on the prevalence of anemia and iron deficiency, as I mentioned before, of women of reproductive age who reside in rural areas of the high-performing intervention district and self-identify as users of the PDS program. So you will notice the adjustment of the objective from the original research objective, that who reside in rural areas of high performing intervention districts. And the secondary objectives were to assess whether a dose responsive effect exists among users of DFS in the high performing district, and to assess the impact of DFS on the morbidity status in non-pregnant women of reproductive age. I'll touch on the primary objective and the first secondary objective. And I won't dwell on the data analysis. We can come back to it. I'll transition quickly to the results. And I'll present the results in three forms: the DFS coverage at endline, the main effects, and also the effects among DFS consumers relative to adherence. So at endline, and I include the midline coverage findings at the top here for comparison. This was the coverage cascade that we observed, consistent with the midline findings, but higher in terms of this current use of DFS and regular use of DFS. Now, in terms of what we found relative to the biological outcomes, we found that there was no difference in anemia prevalence or mean hemoglobin concentration between intervention and comparison. So if you look at this table here, we see categories of any anemia, mild anemia, moderate anemia. And we see that when we compare the intervention and comparison districts, there's no significant difference that we realized. And if, when we look at mean hemoglobin concentration, the similar result. But we did find that DFS significantly improved iron status. So if we look at the distribution of adjusted ferritin by treatment, with blue as the control or comparison district and the red being the intervention districts, what we see clearly is that the distribution shifted towards the right. Well, the distribution of the intervention was towards the right compared with the control. Additionally, what we see when we look at the control district and then characterize the intervention district according to no or low DFS use, partial DFS use, and full DFS use, it might be hard to see or discern this, but I'll just point it out that the control is the distribution is somewhat to the left, and as you move from nil or low DFS to partial DFS to full DFS, the distributions shift further and further to the right. These observations are illustrated in the following analysis: that among all women, there was a 17% lower risk of being iron deficient among women in intervention areas. So if we look at the proportion of low ferritin, the adjusted mean difference was 0.83, which the risk ratio was 0.83, which is what translates to this 17% lower risk, and it was statistically significant. And also the mean ferritin levels were higher. When we look at the adjusted mean difference, were higher among the intervention compared with the control district. And then, as the second distribution I showed illustrated, there is a clear dose response of DFS use on iron status. So relative to comparison districts, we see that there's no significant difference when you compare the comparison district and women in the control in the intervention district who did not use DFS or used it minimally. But then women who consumed DFS in intervention districts had lower risk when we compare the regular users and the partial users. So among regular users, there was a 23% lower risk of iron deficiency, and among partial users, a 20% lower risk, which confirms this dose-responsive effect that with more DFS consumption, risk reduction is greater. So based on these findings, what we can conclude is that DFS can make an important contribution to the reduction of iron deficiency. And iron deficiency remains an important public health issue among women and children in Uttar Pradesh. But from the midline findings and what we saw pertaining to some of the bottlenecks to uptake, these effects can be realized or can be increased only if implementation challenges are addressed. And this is a fact that's true for all programs. This is not, it's not a constraint that's unique here. What is impressive that despite these challenges, and also despite the shortened period of exposure to the intervention, we saw the results that we did. But for us to achieve our goal fully, specific challenges must be understood in order to identify a solution. And this evaluation surfaces these issues, and the issues are resolvable. And they range from ensuring premix quality, the supply chain and forecasting support, most of which was accomplished in this program, if we look at the proportion of women who procured. But in this context, consumer awareness raising could have been important in order to mitigate against some of the challenges in uptake that were seen. So these three issues must be or could be addressed in order for us to see an even higher impact. So in terms of what we recommend based on what we found, we recommend that the UP government consider scaling up the DFS program through PDS in Uttar Pradesh. This would reduce the burden of iron deficiency among women by almost 25%. And we recommend that we ensure that implementation follows good practice in order for us to see even greater benefits. We strongly encourage the government of UP additionally to develop and adopt a comprehensive anemia prevention and control strategy for women and children and adolescents as well, even though they were not the focus of our evaluation. So iron deficiency is only one of the many causes of anemia in all contexts, and in particular the UP context, and particularly inflammation and also other nutrient deficiencies, which have been clearly illustrated by the etiology analysis of the state survey data. So I think we know and we confirmed in looking at the etiology of anemia that iron interventions could only ever be a part of the solution and not the full solution in its own right. So in this at this point, I will stop here and thank you for your attention and for the opportunity to present these findings to this esteemed group.